Good afternoon, everyone, and welcome. I'm Catherine Brookman, Associate Director of Knowledge Transfer and Exchange, and on behalf of Dr. Jack Callahan, Director of the Center of Research Expertise for the Prevention of Musculoskeletal Disorders, or CRE-MSD as we are more commonly known, we'd like to thank you for joining us today for this free webinar on the landscape of safe patient handling and mobility regulation across the United States. Trends and gaps. This is the first of two webinars that examines the policies, practices, and injury trends related to safe patient handling and mobility across the United States. We are grateful to the Ministry of Labor, Immigration, Training, and Skills Development for our funding, which supports the delivery of these webinars, and to our presenters who provide their expertise. CRE-MSD has recently switched video conferencing platforms and is now using Zoom to host these webinars. Please bear with us should we need to address any technology issues that occur during the webinar. This webinar will be recorded, with the recording being made available to you along with the presenter slides shortly after today's webinar. Participants' names will not be visible in the recording of the webinar. The format of today's webinar is as follows. The presentation will be given, after which time we will have 10 to 15 minutes for a question and answer period with our presenter. Please refrain from using the raise hand button, as we will not be monitoring this feature or any other meeting reactions. During the question and answer period, we ask that you type your questions into the chat. The chat feature can be pulled up on your screen by selecting the chat button in the control panel that appears near the bottom of your screen. I will relay these questions to our presenter, or a similar question should we have duplicate themes. Your video is disabled and you will be muted for the entire presentation to ensure there is no background noise disruption. Should you have a pressing question or issues such as a technology glitch which cannot wait until the end of the presentation, please type this into the chat and we will do our best to address it right away. Tomorrow you will be sent a link to an evaluation. Please fill this evaluation out, as it will assist us in the future delivery of our webinars. Thank you so much for joining us today. And if you have not already visited our redeveloped MSD Prevention Guideline for Ontario website at msdprevention.com, please do. And we hope you will join us for our next webinar in this series on Wednesday, April 23rd, for the Minnesota Safe Patient Handling Statute, a case study. Now it is my pleasure to introduce to you today our presenter, Dr. Adam Moskowitz. Adam is an occupational health and safety researcher trained in injury epidemiology and labor policy. His research has focused on occupational injury among precarious workers in the healthcare industry. Adam is a recent graduate of the NIOSH supported doctoral training program within the University of Minnesota's Midwest Center for Occupational Health and Safety, and is currently a research associate with the University of Iowa's Healthier Workforce Center of the Midwest. Thank you, Adam, for agreeing to do this presentation today. Now over to you.
Right. Thank you so much for that introduction. Thanks everyone for being here. Very excited for being here, and I'm also looking forward to the next webinar in this series with my colleague Brecca, who was actually super helpful in helping me develop this research. A lot of what I'm going to talk about today was from my dissertation research, and Brecca and I both live in Minnesota, so she was a really good subject area expert to use, and I was actually directly involved in some of the research I'm about to present today. So thanks everyone for coming, and again, I'm currently a postdoctoral researcher with University of Iowa Healthier Workforce Center of the Midwest. So great, a little background. First of all, on terminology. So the way I'm used to saying this topic is safe patient handling and mobility. That's probably what I'm going to be using to refer to for the rest of this presentation. And I only really recently, from talking to Catherine, have kind of picked up on, in Canada, this is referred to as client-patient handling. I wanted to make a note of this because I actually think that client-patient handling is a much better term. Some of, I think, the subtext, or really the text of what I'm going to talk about today and what a lot of my work was really trying to expand our understanding of these sorts of activities and hazards and injury risks from just the narrowness of the healthcare setting or the most narrowly defined healthcare workers. These sorts of maneuvers can happen anywhere, um, and it's not always just plain nurses who are doing them. I was recently at a vendor for safe patient handling equipment in Minnesota who were talking about all of these contracts they were recently getting to put in like sit-to-stand lifts or adult changing tables in sports stadiums and public schools, airports. And so, yeah, the people who need this technology are not confined to the narrow physical locations of healthcare facilities like hospitals. And one thing one of these folks said when I talked to them that has stuck with me is that they said everywhere you look around and see an automatic electronic defibrillator, there should be like a sit-to-stand lift or a fall recovery equipment. So I thought that was really important. So again, all right, a little more background, which is probably uh, a review for a lot of you, but healthcare workers in the US, and I'm sure in Canada as well, have among the highest rates of musculoskeletal disorders of any occupation, and that's especially the support occupations like nursing assistants and folks that have less certification and less training than nurses. And these groups of workers are also experience some of the highest rates of workplace violence of any occupational group. I know that the bulk of this talk is going to be on safe patient handling, but I really think these two things are entwined in ways I'll talk about in more detail later. But if you think about it, the etiology of both of these injuries really comes from close quarters and physically intimate and demanding work. Um, and a lot of high tension things can happen when a healthcare worker is doing a really physically intimate thing with a patient who might not be in their fully present mental state. And so I really think that there needs to be some sort of connection between these injuries, and perhaps we can look at root causes and how to reduce the risk for them. And then finally, in the US, as I'm sure in Canada as well, it's an extremely diverse workforce and very heavily made up of immigrant women. Yeah, precarious in many ways and lacking some protections and ability to speak up in many ways as well. And so why is this important? Why am I talking about this? On the United States, there is no national ergonomic standard for the protection of people at work. There was one passed, I believe, in the year 2000, which was then vetoed by Congress at the time. And so since then, there's been patchwork legislation throughout the states to address both ergonomic hazards generally, but also safe patient handling specifically. And there's been, a fair amount of research on specific states. I'm going to talk about a little bit in Minnesota later because I was involved in some, and I'm sure Brecken next month will also talk in much more detail about that. And there's evidence that this is important, and obviously companies themselves or healthcare employers can pass their or implement their own safe patient handling policies, and many have very successfully. But beyond self-regulation and being able to have resources within state governments or in government in general can be very helpful for workers who want to know how to deal with these hazards and how to keep their workplaces safe. So I guess the basic methods I'm talking about today, I'm really talking about the first manuscript that came out of my dissertation in which I did a type of methodology called policy mapping within like the field of legal epidemiology. Basically, this is kind of like doing a systematic review, but instead of reviewing peer-reviewed data, publications or data or things like that, we reviewed state statutes that were passed in state legislatures within the US. So we had but it is done systematically. So we had a search strategy, which you can see here. Myself and another researcher went through and coded each statute that we found that was relevant using a coding framework that we came up with based on prior research of what, aspects of a safe patient handling law or program seemed important or effective or commonly used. We also talked to subject area experts, including Brecca, who will be speaking next month, and thought about what was already on the books for existing laws. And we achieved 100% agreement between the coders for this, which just meant that every single thing was coded twice. And we came together to make sure that we were in agreement about what each law was saying. And so to do this, we use this pretty cool tool that was developed by the Center for Public Health Law Research out of Temple University. They have something called Monocle, which is an online tool that makes this very easy. I always like to give a plug for it because I thought it was just a great way to organize all this data. And I was playing around with it yesterday. It does seem that they have municipalities for Canada you can use, though the website is more US framed, I guess. So the broad results from this, and this map was generated with Monocle, so you can visualize your data in nice ways like this. But between 2006 to 2022, which were the dates of data capture for this project, 11 out of the 50 states enacted a safe patient handling policy. 2 of those states repealed those policies, so I put X's by Missouri and Ohio before the end of the study time period. And then an interesting note, or an interesting to me, is that Minnesota and California passed these as state OSHA standards, whereas the rest of the states passed them as hospital health codes. I think this is interesting because a handful of states within the US have their own occupational safety and health administrations within their own state governments, whereas the rest of the states rely on the federal OSHA office to do their workplace health and safety enforcement. And so the fact that Minnesota and California did this means that it's essentially a workplace safety standard in those states to have a safe patient handling rules. The rest of the states is part of like how hospitals get their licenses. So essentially this means there's differences in the enforcement mechanism, in how often and who would be doing those sorts of inspections, and the routes by which workers or other people could voice their concerns. I don't really know the full implications of this yet, and I think this would be an interesting thing to look into for further research, but that was just a note I wanted to make. And so here are the real main results that we're going to dig into, and I will break this down further in the following slides, but just to give you an intro to what we're looking at here. On the left column, these are the jurisdictions that came up positive in our search for having a safe patient handling law on the books. And so these are the states here in the left column. On the top row, you see the main aspects of each law we were looking for, and generally if they had that aspect of the law or if they didn't. I vaguely organized this so that on the left hand of the screen were the more common elements of the laws with yellow yeses, and on the right hand were things that were less common but still showed up. And then this column here, industries covered, refers to what different types of healthcare workplaces were covered by each law. Each law had to make decisions about who to include and who to exclude in their definition of a healthcare setting that needed safe patient handling regulation. So I'll break that down more, but we're talking, hospitals versus nursing care facilities versus outpatient care centers, etc. So to get a little deeper into this, over here on the more common side, what almost every state decided to put into their laws, we have first hazard assessments, which is just the evaluation of a patient base and their mobility needs. I think this generally means like per unit or per floor, so that a hospital who's affected by this law means that like, you know, their med surge unit would have to say, okay, this is like probably the general mobility level and safe patient handling needs of who's going to be coming into this floor. That's going to look different than you know, intensive care or things of that nature, or a long-term care nursing facility or an outpatient care facility. So as long as all this is written down by the employer or the unit, then that's generally what that part of the law refers to. Next, you have safety training. Pretty straightforward, the requirement that workers understand lift procedures and the equipment. Some laws go further and say that training is required every year, or that a refresher training might have to be, you know, is available at any time an employee wants it. This can be important for, you know, onboarding employees, or perhaps there's a piece of equipment that like really just doesn't get used that often. So it can be important to make sure that a worker isn't just thrown in like into the deep end without knowing what they're doing. And then safe patient handling committees. And so these are like joint worker management entities for deciding on specific safe patient handling policies or monitoring internal data of their own injuries or patient injuries or things like that. Usually the worker side is made up of folks chosen by union, or there's some sort of like union management collaboration here on that. And I think every state I looked at requires a 50-50 split between frontline workers and management. So those are all pretty common. And it kind of, when you read all these laws, it kind of seems clear that like a lot of language gets like maybe even copied and pasted between them, but probably pretty standard. And then over here, we have some more interesting ones that are less common. So first is the right to refuse an unsafe lift. And more importantly, or perhaps more specifically, this is protection from retaliation for refusing an unsafe lift. So if a worker, you know, is in a situation where they're like, no, I shouldn't do this alone. I should wait for some equipment to arrive or some more people to arrive. This essentially bars their employer from retaliating against that worker. So a few states have that. This other one, lift teams, basically requires that a covered facility or a covered employer employs lift teams. And so those are just trained specialists for all they do all day is operating the safe patient handling equipment, or making sure that nurses know where it is, know where to find them, know how to use them. And so I've heard anecdotally and from qualitative research that I've read that this can be really important for nurses, because it really does just sort of take a whole lot of work out of their mental space that someone else can be focusing completely on this. But it is still hard with just the scarcity of time and the scarcity of people. And I think we'll talk about this more later, but sometimes, you know, the lift team is there, they exist, but perhaps they're way down the hall and you need them really soon. And so then the last two, and these two I think are kind of some of the most interesting, are public funding for safe patient handling programs or equipment. So only Ohio and Minnesota, it looks like, had these, and Ohio's law was repealed. But basically, this is like a state-backed, usually either grants or like zero interest loans, so that employers, and sometimes perhaps they have to be like a smaller employer or with less capital, that they are able to use that state funding to purchase this really expensive equipment. I think this can be super effective, and there's evidence of this being effective in other areas as well, not just safe patient handling equipment. I believe Ohio kind of actually has their workers' comp state system has a pretty good history of like working so that public investment in safety equipment is a pretty big practice there, which I think is really interesting. And then finally, requirements for new facility construction. So this is like saying that after the date that the law becomes effective, all new hospitals that are built or all new healthcare facilities that are considered part of the purview of the law that are built, they all have to meet the physical needs of accommodating the safe patient handling equipment. So the rooms have to be built in such a way so that the ceilings can support the ceiling lifts and everything's wide enough to like get the equipment through, or like, you know, wall mounted, ceiling mounted stuff. So this can be really important as well. And anytime there's a renovation that happens, this is required by the state that you need to physically manipulate the environment in this way. So the reason why I'm talking so much about physically manipulating the environment, which I'm sure probably a lot of you are familiar with this as well, is because of the concept of the hierarchy of controls. And so as I was reading through these laws, my mind kept coming back to this as a useful way to organize them and think about them. And so the hierarchy of controls basically says that in order to limit injury or limit adverse events, taking things as much as possible out of like individuals' decision making and room for individual error, and more towards physically changing environments or eliminating hazards or eliminating the possibility of an adverse event is always the most effective way to go. So the most obvious or relevant for recent years example of this is the coronavirus when it was circulating our airways. The best thing possibly to do would be to eliminate the virus from our physical spaces. And the least effective but like cheapest and quickest way would be to distribute PPE in the forms of masks and respirators. And then in the middle here, substitution would be like substituting a hazard for something less dangerous, which is less relevant now. But the two that I really wanted to focus on were engineering controls and administrative controls. So engineering controls would be like, engineering a way that the physical environment can be changed somewhat, or to build barriers between the worker and the hazard. And administrative controls would be like using policy and rules to change the way workers work. So examples of engineering controls in these laws are like making sure that that equipment is available. Not just that you have it, but that it is readily available and usable at all times. Or requiring and funding new facility construction to certain codes so that the physical space of the facility can foster a healthier working environment. Administrative controls are more like those administrative or rule or policy-based things, like requiring that committees are formed, or requiring safety training, or requiring hazard assessments. At the end of the day, all of those are intended to have workers make better decisions, essentially, rather than physically changing their environment. I put an asterisk by lift teams because that one is a little bit in the middle. Certain workers are still, I guess, technically exposed to a hazard if they work on the lift team, but their whole kind of role also is to insulate other workers who are not as specialized in that sort of activity. So that one I put an asterisk by. But as you can see, the less common ones are the ones that are more expensive but more effective. The more common ones are less expensive and also less effective. And so I think there's some interesting patterns as well too when you look at the coverage by healthcare setting. The names of these settings I used from the North American Industrial Classification System, or NAICS codes, which is the language that some of these laws are written in. I am not sure how widely used that is in Canada, but it does say North American in the title, so I assume It's still pretty widely used. So as you can see, number one setting or subsector would be general hospitals. Every single law considers general medical and surgical hospitals to be, the space where safe patient handling maneuvers exist. And then also pretty common are other types of hospitals and long-term nursing care, skilled nursing facilities. So all that makes sense. But then you get down here to some of these less common ones. You have 2 states covered outpatient care centers, 1 state each for surgical centers and assisted living and retirement communities for the elderly. This one I really wanted to point out because, as I mentioned at the top of this presentation, if we are beginning as a society to realize that airports, schools, sports stadiums, all these places, if these are areas where safe patient or patient client handling happens, then I think it's really clear that it definitely is going to happen at an assisted living facility for the elderly. Oftentimes, assisted living facilities will have something that resembles like a nursing care in, more intensive, higher acuity care, like a wing within it, even though plenty of the folks who live in a retirement community might be very healthy and very mobile. So the fact that they are not included in these laws, I think, is very significant. And similarly, the residential disability, mental health, and substance abuse facilities, also known as group homes, no states covered those. And I included that as a 0% because they're very common in Minnesota. I believe Minnesota uses them more than any other state in the US. So I have somewhat of a research focus on them in one of my other papers, and I'll talk a little bit more about that on a few more slides. And so you can see, there's another pattern here that the higher acuity settings are more commonly covered than the lower acuity settings. And like the pattern here, I mean, this makes sense. I don't want to drag this too hard because like you want to get the most bang for your buck. You want to prevent as many injuries as possible with as few resources as possible, obviously, but this is still going to leave a lot of gaps. And I think it's really important that we just are very explicit in figuring out what those are and work to cover them. So what are the gaps? So generally, by setting, those lower acuity, longer term style care settings like have gotten less policy attention. That's where the more precarious and less skilled workers are going to be concentrated. More of the nursing assistants and healthcare support occupations that are less unionized, more often immigrants, more often immigrant women. And safe patient handling is still a factor in many of these settings, even if sometimes the patient base is more ambulatory. So on the right, this is a photo from a group home in Minnesota. A lot of people think of group homes as like, you know, perhaps like it's where minors live when they're in the foster system, or it's where people are staying if they're having like, mental health trouble or just like, more, I guess, like mental issues. But obviously a lot of people with physical disabilities live there as well. And just because they operate out of residential houses doesn't mean that you can't have safe patient handling equipment installed in them. This is another thing I talked about with the vendor of safe patient handling equipment I met with a few weeks ago, that absolutely houses can be retrofitted to have this equipment. So I think that's very important. And then also by the content of the law. It's pretty clear in the background literature on all this that time and staffing levels are often a key reason why these procedures are overlooked and really just contribute in general to, I think, the stress and turnover and burnout and injury risk from healthcare workers in general. And this is also where I wanted to come back to a bit, the issue of workplace violence and how it might have a common etiology or theoretical link with these same issues, time, staffing levels, and the sometimes just like inappropriate ways that that workers are asked to work in extremely intimate, close nature with their patients or clients without the proper supports for them. And so to get a little more into this kind of gets into one of my other papers that I wrote for my dissertation. But one of the things we did was we looked at workers' compensation claims from group homes, and we were able to access like narrative descriptions of each injury claim, and then rather than uh, relying on the way that it was coded by the insurance company and into the nature body part incident type coding, we just read them to see like, okay, because of possible misclassification of what could be workplace violence, what could be safe patient handling, we're just going to recode these all ourselves. And so this is what we found, is that basically 50% of all claims in total coming from group home workers involved contact between them and one of their clients or a resident at the group home. Um, and then, yeah, this yellow here, that was like unambiguously was a safe patient handling injury. It was like worker was bending over a bed and then hurt their back. Uh, this here was like unambiguously workplace violence or assault, like they were pushed by a resident or something. And this red one here, I guess like a sixth of all claims were just too ambiguous for us to be able to say they were one or the other, or were clearly both. So something like a worker was assisting a resident in toileting, the resident became agitated and then punched the worker, things of that nature. So like clearly both things were happening. Um, and that's in group homes, kind of like, they're a specific thing, but I think this can be really instructive for thinking about how do we think about common etiologies and root causes of what is just a really, for a lot of these workers, like a daily part of their work. They go to work and this could happen to them at any moment. This is a little bit more from some other parts of my research. I don't know how deep into this I want to go because I think this gets close to what Brecca might talk about. But another paper that I worked on through this was analyzing the effects of the Minnesota state patient handling law using various sectors of the healthcare system that were covered by that law and several that weren't as control groups. So in this case, just because I thought this is a very stark contrast, the skilled nursing facilities were like an intervention group, and retirement communities or assisted living communities, they were the control group. They were not affected by the law. And so we have some different time periods here. I meant to relabel these, but this is like pre-law from 2003 to 2007. The two in the middle were sort of considered like intervention or implementation time periods rather, while employers were coming up to speed. And then from 2014 on, everything from the law was supposed to have taken place by then, all of the changes. And so there's a pretty significant change in terms of injury reduction in the nursing facilities, going from about 7.5 to 3.7 injury claims per 1,000 workers of safe patient handling injuries, or a 50% reduction, and then a much more modest decline within retirement communities, the control group, a 27% reduction. I don't need to get too into the methods here, but I just want to point out that we tried our best using the data possible to focus only on safe patient handling injuries and also only on direct care workers. So each of these ratios and denominators, we actually looked at like the proportions of people's occupational classification codes to say like, this is only supposed to be 7.5 claims per 1,000 direct care workers. So nurses and nursing support occupations versus the direct care workers that are employed in retirement communities as well. So actually all three of the papers that I worked on are all in the process now of hopefully being published soon. Please be in contact if you want to be kept up to date about that. And so, yeah, just to summarize things here, what has seemed to be the trend in the US for this so far, and I'm really curious to hear about what the experience has been like in Canada. But in general, administrative controls have been favored over engineering controls. And hospital and high acuity settings have been favored over residential and long-term care settings. Again, there's definitely absolutely logic to that, but I think, we should be setting goals for uh, covering the gaps as well as possible and being extremely clear about what those gaps are. Um, and what also gets uh, complicated in this is how wide a range in policies these are. So I think it can be really hard to point at, say, you know, perhaps one state will be like, well, Maryland passed, this is me just saying stuff, I don't know if this is true, but Maryland passed the safe patient handling law and they didn't have any reduction in injuries. Like, why should we pass it in our state? Well, Maryland's law has a pretty narrow set of requirements just for the safe patient handling committee, as opposed to, some of these other states that had more requirements or more perhaps material support for changing the workplace. So this makes, evaluation research more complicated. I think you really have to pay very close attention to what is happening in which state specifically. Um, and so, yeah, this, leaves us with a few more questions for the future that I would love to work on someday, or if other researchers are out there would love to work on. This one is a little more US focused, but I am very curious about if OSHA standards are more or less effective than hospital licensing regulation. Brecca will probably talk about this a little bit next month, but she works in compliance with Minnesota OSHA, which basically means that, employers can reach out to her to have the resources of the state to really, if they are in good faith, really interested in reducing their injury burden, then they can reach out to her and she'll help them with that. But OSHA also has, an enforcement arm where workers can make anonymous tips and have worker representatives, uh, help fill out reports of violations and things like that. And so there's a whole, system and history for how things get done through OSHA. And I really know a lot less about how hospital licensing works. And so there's just two different methods of enforcement there, of investigation. And so that's something I'm really curious about. Because also, as you might recall, had the federal OSHA ergonomic standard passed in 2000 and stayed on the books, then actually none of this would probably be happening. And so there'd be a whole different world from that. And then finally, I think the really big question, it gets back to this idea of common etiologies and root causes, and can interventions in other areas of concern also improve safe patient handling outcomes, or for that matter, workplace violence outcomes, or healthcare worker mental health and burnout? Um, I think, on some level, we should think about perhaps not, I guess, quarantining these problems too discreetly and think about what might be some of the common sources and common interventions we could come up with that could perhaps benefit more people down the road. And so then whenever I give presentations on this stuff, I always leave with this image on the left here. This is from a nursing manual dating back to 1898, and you can actually see a ceiling-mounted safe patient handling lift, which was recognized as a hazard even way back then. So, not a new problem, and yet we really only started in the US um, addressing this with the power of law in the 2000s. So this comes about to the end. I just want to do some quick acknowledgements from the University of Minnesota, where I did this research, the University of Iowa, where I now currently work and does really good work as well. They're a little more total worker health focused than the injury focus of the talk I just gave, but they do great work there. And then Brecca Cheetah, Neil Rigerman, Evelyn Dorn, and Katie Schofield, who are all sort of helped with the policy work and coming up with that policy coding protocol, and the Association of Safe Patient Handling Professionals, who have been a great resource for this as well. So it's 11:40, and that is the end of my talk. If anyone has questions.
Well, thank you so much, Adam. We really appreciate this presentation. Really helps us think about what is and isn't happening in Ontario, helps us think about the hierarchy of controls and where our own organization's emphasis is and why is that. One of the questions that occurred to me right away was, early on you talked about two jurisdictions that repealed the policies. Can you say a little bit more about why? Do you know why, or you weren't able to talk to them, or you didn't follow up with them?
No, that is a really good question, actually, and I should have an answer. So that, in the way that like the methodology of that sort of paper is supposed to work, technically you're supposed to be analyzing the contents of the laws. So that sort of context feels like obviously very important, but extra. So I didn't actually it wouldn't, I guess in other words, what I'm trying to say is the content of the laws would not answer that question for me. I would need to like, read some news sources and like get into the wider context. I would guess so that like the Ohio law, which I think is one of the, even though it didn't really like have much prescriptive about it, it didn't say that you had to do any of these things. It did, it was like a very short law. It was like a paragraph long, and it was just like, the Ohio Department of Labor is going to have a fund now where you can buy safe patient handling equipment with it. I imagine, as the politics in Ohio have changed, perhaps the legislature has been less interested in that sort of public investment, in cutting state costs and things like that. And the other law was Missouri. And this is interesting too. I mean, it's like this law doesn't really require much. The hazard assessments and safety training and safe patient handling committees. So Missouri, I don't know. That would be interesting to see how they walked back on that. But you know, as I said, like some employers have been really into this kind of thing. There's I think I remember a good paper out of Massachusetts that I read while doing back literature research on just, yeah, a hospital system employer doing their own safe patient handling policies without being required to, and it just, lowering their workers' comp costs and things like that. So some employers are really into it, but I would not be surprised if many employers lobby against these sorts of things as well.
Something really interesting, I mean, down the road to follow up with some of these jurisdictions. It is outside of certainly what your dissertation was looking at, because it's more than just that jurisdictional review. It's the interviews and possibly focus groups and analyzing data around the impact of what they did or didn't do. I'm encouraging our participants to type any questions you have into the chat, and I will relay them to Adam. Another question was, you talked about the control group, and you showed that they did have a reduction. Do you have a sense of why? I mean, they weren't affected by the safe patient handling law. Is it because they knew about it or were aware that it was having an impact? Do you have any sense of the reduction results?
Yeah, that's another great question. And so I will admit, I ran this analysis on like 7 or so different industries. About 3 or 4 were intervention, 3 or 4 were control. Um, and I'll admit I did kind of cherry pick the starkest one here. But you'll see that like, and this is all going to be reported when this paper gets published. There is some element of like it's not all this stark, and uh, there is injury reduction in the industries that were not covered by the law. And so myself and my committee, we talked a lot about, okay, like what could be the reasons for this? And I think, yeah, there are probably several, and I think you probably hit on a couple of them already. So by just this law being passed, I mean, that means that any employer in the wider healthcare industry, like, is just going to know about it all that more as an issue. And so there's just, I think, like, public awareness has gone way up about this stuff. The availability and quality of the technology and equipment has gone way up in the last, 20, 30 years. Um, and yeah, and I mean, it just makes sense to do, like, you don't have to be required. Again, you don't have to be required by law to do this. I think if you're paying attention at all, you're going to realize that it's going to lower your workers' comp costs and your workplace injuries, and your patient injuries, quite possibly a whole lot to take this seriously. So I'm sure there's some element of that being reflected in just the um, uh, decrease in injuries across the board. I get into this in this other paper as well, but on the flip side of that is that workplace violence injuries have across the board been going up in all of these industries. I think there could be some uh, reasons for that relating again to sort of like cultural change, and people are probably more open about talking about that kind of thing than they were like 20 or 30 years ago. And so, what we're really looking at is what's showing up in the data and injury surveillance data that we can have access to. And so, while some of it might be, yeah, like these sorts of cultural changes, others might be, well, and maybe there just might be more workplace violence happening now too, in general. So there's a mix of both of those things, what's happening in reality and what's showing up in the data. But yeah, that's a really important point too. And I believe just in general in the US at least, like since the 70s, most occupational injuries have been going down. Like that is like the wider trend, a macro trend, if you will. So, the part of the methodological trick for stuff like this is to be like, okay, where is it going down faster and why?
We've always had a challenge in Ontario of workers reporting um, an injury before it gets so bad
Mhm.
that they're not coming to work. So
Yeah.
they're experiencing, when I say reporting an injury, they're experiencing back pain as a result of repetitive lifting, but they don't say or do anything about it because one, they need the job, or two, they're afraid they won't get the hours or the shifts they need. Um, there's been a lot more reinforcement and policy support around, we want to know early on so we can help deal with this. Uh, so that certainly is a trend for us, that I guess there's more of an encouragement of our workforce, especially our personal support worker workforce, whether or not it's difficult to say whether or not that's making a difference until we actually analyze it. Surprisingly, our participants are shy. I'm shocked because this is a topic of passion for them. So I will just ask you one more question if I don't hear from some of our participants. Do you know, and this may be beyond what you're looking at, but are you aware of any workplace costs going down as a result? Is there rebates in terms of insurance that employers may pay when injury rates go down?
Yeah, so that is a very state by state
Mhm.
process in the US. I can't speak with a ton of specificity about that. Um, but in general, yeah, I mean, I think this is like an interest again for a lot of employers and related groups because as you all probably know, if you're in the, MSD world, these sorts of injuries go straight to the back or lower back, and these are just often some of the most expensive injuries you can have. So, just a lot of people leave their industry because of injuries like this. A lot of people require huge amounts of workers' compensation payments because of this and medical care. Um, so yeah, I think that's why, again, one of the reasons why you're seeing reductions without state involvement necessarily. Um, I see there is a question in the chat on training. So
How are staff
yeah.
are staff trained, and did you look at the type of training online versus in person or duration of training?
Um, Another very good question. So these sorts of requirements in terms of like the specificities of how those trains happened, those usually aren't written in the law. That would be good to know. I could look that up. I think that might, because of the nature of this project, I really could only look at like what is what is required in the law. Employers shall do such and such. And so there, I do have, this is a very simplified version of the table that I have. What really I have is like several more like sub bullets between these. And for training, um, what you would see like sub my sort of like primary question on our training is required. There are a couple sub questions. Those questions were basically like, is training required every year? Um, are refresher trainings available for workers who request them? And so those are the only things that were ever really like spoken to in the language of the statutes. Statutes wouldn't usually dictate like that it has to be online or has to be in person or the duration.
Right,
Um,
right.
but so yeah, that kind of gets into like employer choice and things like that.
We're always
Um,
looking at the effectiveness of the training, and
mhm.
there's we could go on and on and on about training and its impact, and we're certainly aware that there needs to be more than just training.
Yes, yeah.
So that's a whole other area. But thank you for addressing that. We have a couple of questions now. For the laws review, is compliance typically a submission required from an employer, or are there OSHA inspectorate visiting workplaces and reviewing measures?
Sorry, could you ask that again?
Yeah, so when compliance is taking place,
Hmm.
is this typically a submission required from an employer? Um, like when the inspectorate comes,
Hmm.
are they specifically reviewing the safe patient handling? I think that's what Lisa's asking.
Oh, okay.
Or she's qualifying it here, saying, what do employers have to do to prove they're in compliance, to show evidence? What do they, is that in the laws?
Okay. I I don't want to. This is really Brecca's
Okay, well,
line
it's
of
a good
work.
question. I'll note it for
Yeah.
Brecca.
Yeah, keep that question for so
Yep,
next month when Brecca Cheetah talks, that really
yep.
like I can kind of fake an answer for that, but that is really that's exactly what she does. So I would recommend keeping that question for her. And I think that's gonna also just I mean she works in Minnesota, so she's gonna speak to Minnesota. That probably is gonna vary a little bit state to state, and I'm not exactly sure how it works for federal OSHA either, for the states that require like rely on the federal OSHA administration to come in. I don't know how compliance works. I've only ever talked to um people who work in compliance in states, in
All
Minnesota and
right.
California specifically. Um,
We'll
so yeah.
definitely follow up with Brecca about it, and it is certainly something we're very concerned and interested in Ontario. You know, our compliance officers go out, they educate and provide information, but then what happens? And so the follow-up piece. And so
Mhm.
we'll talk definitely to Brecca about this. We have another question in terms of assisted equipment. Are you aware in the laws, is there any information about the type of equipment that may have contributed to the reduction in injury rates? In the past, someone has indicated that they worked in occupational health departments in various hospitals where equipment needs were identified, but there was too much focus on training and not on equipment. So again, I know you can only answer this in terms of the what the jurisdictional laws policies had to say. Was there any EGs or specifications related to equipment that you saw?
Not in the law, no. I mean, something that, I would see come up in the law sometimes that I don't have in this table, but I have in my, I guess, like more detailed versions of this, is something I would refer to as a zero lift policy, which basically meant that like there is going to be zero unaided manual lifts happening in the hospital or whatever. Um, I didn't have that in this table because I thought it was, well, I wanted just to limit the text, but yeah, I kind of also sort of thought of it as just very tied to some of these other things. No, the laws usually did not specify types of
Yeah,
equipment.
yeah. Normally they don't, but
Yeah.
we thought we'd ask.
But I don't know that like the people who are like I'm not like an trained ergonomist or anything, but I know that people who are have like a lot of very serious opinions about this, and
Mhm.
some if certain types of technology is outdated, but they're like still used in a lot of places, people get very upset about that. So, but that I'm not trained in that, unfortunately.
I have one last question for today, and that's, do you know how staffing impacted injury reduction? Do any of these states have staff ratio requirements that you're aware of? You may not be, but we're going to ask it anyway.
Yeah, so I only know about this kind of on the level of my like background literature search. I haven't done work on this personally specifically. It's something I would be interested in though. But in general, yeah, like from what I've seen in the background lit I've seen, safe staffing ratios can be extremely helpful. And I also tried to pay a good amount of attention to qualitative research, interviews and focus groups and things like that, publications that came out of those. And something, actually, somewhere I cited one of these on a slide. Let's see. Okay, this is not the one I was thinking of, but yeah, this I think was maybe from a survey, barriers to the use of assisted devices in patient handling. These sorts of things just come up really commonly. People saying things like, you know, we need to do this maneuver in the next 60 seconds, and the lift team or the equipment is 4 minutes away. So I think that, a good rule of thumb would be to assume that you can help solve a lot of problems with more staffing. But yeah, that's not something I have firsthand experience with, just really on the level of background research.
Something else for us to look at in Ontario. We, back in the day, and I'm not sure what's happening now, but adult day programs used to be in the community funded with more generous staffing ratio allotments.
Mhm.
Not sure if that's continued, but also when you're looking at the different types of clientele, frail, stroke, dementia, there were also some arguments and data related to increasing staff-client ratios for quality of care. We have run out of time, Adam. Thank you for giving us a fabulous foundation and preparing us for Brecca's case study talk, where we will actually learn what are the results when this has become legislation and compliance is looking at what you're doing and how you're doing it. So we look forward, hopefully, to seeing everyone again on April 23rd. And thank you so much. You have sparked so many potential research projects and questions for us. Thank you very much, Adam.
Yeah, absolutely. Thank you so much. And yeah, basically every question that everyone asks that I'm like, oh, I'm too high level for that, Brecca will have a better answer. She's going to be more on the ground than me. So
Well,
yeah.
you did a great job in laying a great foundation for us to help us understand where Brecca is going to be coming from and what led up to what she's going to be presenting. Thank you so much.
Thank you.
And thank you everyone for joining us, and we hope to see you on April 23rd.